Okay, and there is something called protocolized weaning, which is more commonly done in the West. Okay, so when we say protocolized, it can either be computer-based protocolized or nurse-based protocolized, what we also known as nurse-driven, where it is independent of a clinician, or it can even be a clinician protocolized weaning, or where they have a respiratory therapist, they can have a protocolized form of weaning, wherein the primary physician or the intensivist does not have choice of action. Of course, if there is something grossly wrong, you can always violate the algorithm. I've purposefully put that algorithm in a font that you will not be able to read, because see, no matter, despite the fact that these sort of prolonged protocolized weanings have shown a significant reduction in weaning duration, despite the fact that they have shown considerable reduction in the number of ventilator days. There is also data emerging that these kind of protocolized weaning could result in more frequent reintubations, especially in our kind of setting. Okay, and again, we often refer to resource limited settings within the context of today's lecture. So we are not yet in a time for protocolized weaning. Rather, we need to focus on more other protocols which are validated, which are more important, which really help us in weaning. I will tell you what. Okay, so again, another thing, you see that protocolized weaning, yes, reduces the duration on mechanical ventilation, helps you come off the ventilator faster, but then it doesn't make a big change to the mortality. But like it holds for any other intervention in the ICU, I think it is not a wise thing to be, looking at an intervention versus mortality, because there are many reasons what affect mortality in an ICU, and it is not just the way that you wean, obviously. Okay, so this doesn't really matter. Rather, what is more important, like I told you, are the so-called complementary protocols. Whether you have a protocol for weaning or not, you need to have some of these very, very important protocols. Like top in the list, I put daily sedation interruption, or otherwise the drug holiday. Again, you need to use some common sense over here. This does not apply to somebody who's on a prone ventilation, who's on an inverse ratio ventilation. It is on somebody who is recovering, probably waking up, where the dynamics are reasonably settling. Okay, you need to give them a daily drug window or a drug holiday, drug-free window each time. And if that is done in a protocolized manner, it can be nurse-driven. Okay, so that definitely helps the patient wake up earlier, be less delirious, helps improve the performance, the neuromuscular performance, and it has been shown to also reduce the number of days on a ventilator. Okay, likewise, there is something called the ABC protocol, that is coupling this DSI with a daily SBT, so also known as SAT and SBT. Okay, spontaneous awakening trial, SAT. So you leave the patient awake, you give them a certain drug holiday or a drug window period, and then have a protocol for subjecting them to an SBT every day, whether you like it or not. Okay, this also has shown to accelerate or speed up the process of extubation earlier. And then one of my favorite mnemonics, the fast hug BID. Okay, many of these also are in various ways important to outcomes of mechanical ventilation, like appropriate nutrition, appropriate analgosedation, because unless you provide appropriate analgosedation, there is going to be a high incidence of delirium, which is definitely going to be counterproductive when it comes to outcomes of mechanical ventilation. Likewise, thromboprophylaxis, head end elevation, ulcer prophylaxis, glycemic control, all of these contribute in some way or the other overall to outcomes of mechanical ventilation. This is the trial that I was talking to you about, or the protocol that I was talking to you about, ABC, which combines spontaneous awakening followed by spontaneous breathing trial. It has shown to be of good in many ways. Greater number of people coming off the ventilator, more people coming off the ventilator earlier, better extubation outcomes, better physiological outcomes, all of those. Okay, so you can try and design your own kind of a protocol. Which is more appropriate for your setting. And when all of these don't work, when the patient moves into something like the prolonged category or a difficult category, there are other ways also which an expert can consider for weaning a patient. Like for example, the adaptive support ventilation, the proportional assist ventilation. There are various other smart care tools. I'm not going to dwell about that. Or you can also use NIV as an extubation mode itself. Okay, or a weaning mode. So if somebody is capable of doing a reasonably low level of a pressure support ventilation if the patient is awake enough, if there are not too many secretions, if the airway is good enough, you can extubate the patient directly over to an NIV, okay, as a weaning mode. Okay, so these are all available for the expert. Okay, likewise, I already told you, nasal high flow oxygen therapy also has come in a big way for various applications, especially in acute hypoxemic failure. So it also seems to be finding some role for those patients where you may want to, the ones at high risk for extubation failure. Again, I would like to stress that NIV or NHF is not a treatment for established extubation failure. Those patients where even before extubation you identify them to be at a high risk for extubation failure, you would extubate them and directly subject them to one of these therapies. It has been shown even NHF, similarly to NIV, has been associated with a significantly well-preserved heart rate, respiratory rate, oxygenation, PCO2, and all our targets. Okay, so if it is an appropriate patient, you can consider this.